All right, so I had a first slide that said all entrepreneurship is accidental, but I don't know what happened, it didn't transfer, but it's true. I still believe that. All entrepreneurs are accidents, but some of them, just the ones who stay, are the ones who are either crazy or very courageous. So this is what I had thought about, and I did this talk in New York before I came here. And it was mostly people who had this idea, and it was filled with academics, with gene therapy and technology, and who had not incorporated the company. So it was this idea of, so some of this thing may be very redundant or very preliminary for you guys, but when I started off, I always felt that this was it. You find a problem, you create a solution, find that it's one of the best, you pitch it, you get funded, you scale it, and you exit. Wow, success story, right? But what it really is this. And when you started this, you started to find out that, wow, I really needed to do a lot more into the problem. Sometimes you come up with a solution and you apply it to another problem, which is what happened to us as well. You have to be able to sell the problem, which means you have to talk to a lot of people. And I talk to 25 patients a day. I have no interest in talking to anybody else at the end of the day, so it is even harder. So for me to sell the problem was like, oh my God, I have to do this all over again, right? So, but it's important because that leads to market research. That leads to really your idea of convincing yourself that the problem really exists. A lot of times we don't convince ourselves enough, I guess. The second part is to convince others that this is not completely crazy, right? So you try to attempt your solution. You have to adjust it, you have to improvise it, you have to improve it, and then you have to go back to the market again. And that's part of, again, you will learn, because when you create a solution that's not really great, you realize that the market really throws it down. So how do you get better? Again, this involves a lot of talking, market fit, then you incorporate issue stock. I promise about half of the academics felt like, okay, I don't want to do this. This is what it takes. So when I asked them, well, this is really how we did it, and this is how back and forth we went to do it. How many of you really want to do it? And only half of them raised their hands. They said, is this really true? I'm like, yeah, it is really true, right? And this resonates with everybody here, I'm pretty sure.
If you've only got one pivot in there, you're doing way better than most of them.
Yes, and I'll show you a couple more there in reality, right? So you have to pivot at least a few more times. I guess you run out of money more than one or twice. You try to scale at least a few times, and then you end up with needing more money, right? So you're just looking for this. So that's a typical startup journey. And this was this is still true, this is what I am. Fortunately, this month has not been much of clinical responsibilities, but if you are trained into basic science, if you are trained into clinicians, you have pressures from everybody else to do things that are innovative. Just seeing patients is not enough. You have to innovate something else. Being in the lab is not easy when you have bills to pay. So I was doing all of that, including, actually, I used to clean my wife's lab here at Vegas, not mine. But all of this was fun. So what it's got me started is, this is how I look, and I'm just at the summit of cloud stress. I don't know if you guys have been there, but it's horrendously difficult to do it, and it's amazing when you get to that point, because it's really, one of my buddies was cramping up bad. I was trying to help him, and we cramped so bad, and we were the last ones in there, and it was almost 5:30 or 6 o'clock, and we were really, for the first time, we were really scared that if we don't get up in time, we're going to be done for, because it's 3.5, 4 hours in it. And my friend goes, we've been popping Gatorade the whole day. What the hell went wrong? Do you know something that's better? And I said, yeah, because Gatorade doesn't have any magnesium. He said, why don't you put it? Well, I can't just put magnesium into it. It tastes horrible. I said, well, here's an idea for you, and that way I can walk. And it's interesting that basically got us started into, it went through kitchens and my wife's lab that we don't talk about because it was hush-hush. We went to the 8-micron filters, we created it and sterilized it and drank it, and we said, okay, this is doable. So we had this This is to say, okay, let's create this for the shortest amount of money, which we will spend. Won't spend any time, money on doing anything on packaging, advertising. So let's roll it out and see what happens. So that was the beginning. This was in Florida, 2018, 2019, and we put it in, and it caught fire. So early success is almost wrong, right? So we were in 65, 70 stores. We were in Lucky's Market. Oh, we didn't have anything with magnesium ring. Let's get it. So we put it. We were there. I even took it the next year. And that's me. That's not on Cloud's Rest because Cloud's Rest is up here. This is El Capitan. And I'm like, okay, yes, I didn't cramp this time, so it worked. So at that time, we looked at it and we said, okay, great, let's keep doing. We created a lot more stock because we were selling out. This was Florida. Why Florida? Because it was clear water. We had a facility, a contract manager who did these niche manufacturing for wet beverages for a very reasonable amount of cost. He was a scientist and he decided to own a factory. So I guess we resonated and connected very easily. We said, okay, fine. So he did it for us. We launched it. We had a great time doing it. So we said, let's scale. Created a whole bunch of stock, created contracts. So let's roll it out. And then this happened. We stopped it. It was in Lucky's and Chamberlain's and other sports things and GNC. And things shut down. And things shut down, stores shut down. Our inventory was locked. We couldn't get our inventory back. There were no new contracts. 3 months, 4 months went by. Stocks were old. They had to destroy our stock. They didn't give us any of the money back because we had a buyback guarantee that if it doesn't sell, there was this clause that we didn't know about, so we learned about it. So inventory was aging. We had still in lockdown, so we had no idea what to do. So we said, okay, we need to do something, either convert or die. We can't really ship it. A lot of our product is locked down. What do? So we waited for a few months, and we decided to obviously pivot. We have to do something. During this time, there was a crazy friend of ours here. I don't know if you know him, but James Lawrence is the only triathlete in the world who has done 100 triathlons in 100 days. One Ironman every day. Nobody has ever done this. Before this, he had done 50 triathlons in 50 days, one in each state consecutively. So he traveled, and he did a triathlon, and he traveled in the night, and he did a triathlon, and he traveled. And he did it in every state of the US. And he was here in the entrepreneurial organization, EO chapter of Sacramento. He was giving a talk. And he said he wanted to do 100, and then he would not do it again. And I went to the talk, and he said, but he's very scared because 50 almost died. By 36, he was almost died, and he still continued for 14 more. So I said, oh, so you're a very crazy man. So we got along with some of the friends. We met him, and I said, this is an easy way. You're just basically going to die. And he said, yeah, what do I do for it? I said, you at least need to do some performance testing and do that. He said, okay, how do I do it? He was a very open guy. So we said, fine, let's do it. So we created some of these formulations. We sent him a lot of our magnac that was available to us. And he trained and trained and trained. And he called one day and he said, oh, I've not cramped in a day. I mean, nothing has worked for me. What do you have it in there? Is this something prohibitive? I said, no, it's not. Everything is kosher. It's not a problem. He said, well, I don't like the wet things because I'm cycling, 100 miles a day. I want something dry. So that was sort of a thing that let's hydrate, but let's lose the water. Why are we shipping water for the formulation? And that was our first pivot. So we said, fine, let's do it. We don't have access to the wet stock anyway. So we had a couple of companies. At that time, our company was called Gray Mountain. Iron Cowboy is his brand, and his thing. And Mark Haney, our good old friend Haney Biz, he said, look, you guys have some really good stuff. Why don't I help? Maybe we can collaborate. So IGH was born, which is now mostly into the integrated gut health, but that's how IGH was born. So he had very specific things of what he wanted. He wanted to lose certain things, he wanted to have different colors, all natural colors and flavors, no silicon dioxide, none of those things. We did it, we got his thing, and he wanted a label on speed sauce. So we went back and forth about speed sauce, but we ultimately said, fine, you can have the speed sauce. We launched the speed sauce now, which is the current Magnac formula. Magnac is basically the geeky term for magnesium, sodium, and potassium. And it's basically, as long as you deliver some of these electrolytes, you can retain these electrolytes, right? And it's active transport physiology. So we launched this, worked out pretty good. We did a lot of booths. We had a lot of support from local community. We actually had a lot of customers, and some of this was driven out the back of James's following already. So I think we learned an important lesson that certain things, influencers can make certain things initially, can open the door as long as your product is good. So we were happy for a few more days. Then a new problem came in because James realized that he signed a contract with us into the company that he would market this, but he didn't realize that he had just signed a contract with another company a few weeks later that he did not think about. And he called us and panicked, and he said, wait, I have a shoot, and it's an electrolyte product. I said, what do you mean? He said, well, they paid me $100,000 last year to keep me afloat for the 100 triathlons that I'm planning and training for. And I signed it, but they said this was all, like an athletic grease product, but they're launching an electrolyte product and they want me to do it. I said, how are you going to do both of these things? You're bound to us. So we went back and forth to say, okay, how do we keep our product, let it go? By that time, people wanted Magnac speed sauce, so they all talked about speed sauce. So we had a second problem. So what do? We knew that the product was good. We knew people wanted it. We had filed IPs, we got a couple of IPs already at the time. So we did another pivot. So that's pivot number 2. We said, okay, let's lose the Iron Cowboy. Let's keep the formulation. Both of us are happy. He's not obligated to be wherever he is. But we rebranded it, kept basically the same formulation. And we use this for hydration. This is the clinical trial that we did in Tahoe, where a lot of these athletes were drinking either water or they were drinking electrolytes. Electrolyte was us, and they were blinded. Basically, they didn't know what it was. At the end of the race, we basically asked them to fill out a survey and said, did they cramp or not? And if they did, how severe was the cramp? We graded those cramps, we published this data, and it was pretty convincing that it could reduce cramping. So that was another important thing, and we published this in a journal, a peer-reviewed journal. I also did I realized that I had a big network of influencers and clinicians who actually influence patients, who can validate the clinical signs of it. And there's a lot of people who actually want good products. They're not just there because somebody else does. And a few of my friends and colleagues, you're walking every day, nurses who are on their feet all day. What's not good about hydrating with something else? So we did good there, good success. We said, okay, pivot number 2 is probably keeping us alive. So during that time, because some of my clients were patients, and some of my patients wanted a magnesium sort of based hydration. A lot of my friends were nurses, started to give them Magnac because these people were ending up in the hospitals and they didn't get enough time to get to infusion centers. If they got to the infusion centers, their copay was $100 every time they got fluids, so they were really, really upset. So this is where we learned that nurses are the best voices. They said, oh, why don't you drink Magnac? So we started getting calls and messages left saying, I'm a cancer patient and I've been using Magnac, and I saw you're out of stock. When is it going to be back? It's a cancer patient using Magnac. Why would you do that? And then it was sort of an idea that, why wouldn't you do this? Because this is really, And it wasn't a subtle thing, it was a huge amount of local patients looking for it who were constantly losing magnesium. So we realized that there was definitely a medical clientele there, that we needed to do it. At the same time, we have realized that we are getting into a saturated sports market, because you may have the best product in there, but the reality of sports hydration is anybody builds a product. You know, now I see Djokovic has built a hydration product. He just came out yesterday with it. And at the same time, Arnold Schwarzenegger had launched Ladder. I don't know if you guys ever had Ladder, but you know, LeBron James and Schwarzenegger had this collaboration of launching Ladder. So I said, wow, we are getting saturated. We're never going to be able to compete with so much marketing, even though our product is good. So, but there was a dire need, like cancer hydration. Let's look at that at least. So we talked to a few people, consultants. We said, okay, why don't we just de-risk this and at least have something going on based on the basal formulation we have. So let's de-risk. Magnac, that was added with HMOs. HMOs are human milk oligosaccharides. They're not derived from human milk anymore. They're synthesized oligosaccharides. You can get them commercially available. You can purchase them from some companies. But let's lose the sugars and create something that is sort of, help hydration in cancer patients. But we need to do something better for these patients, because if you don't heal the gut, it's just going to keep going. So that was the problem with Magnac. Patients felt better, but they did not heal, did not do anything for their gut. So our best guesstimate was that the HMOs that have so much data on pediatric, GI might actually help us in this. So we sort of formulated this initial batch. And why is this relevant? I mean, this gets to the kind of the core of what we're doing right now, is that there's 15 million people that are estimated to receive chemo. And if you look at any patient who gets chemo, I write 90%, but I have no problem saying that every patient who gets chemo gets dehydrated. And now, the standard of care is we just copiously hydrate these patients before they even get the first dose of chemo. Why? Because we know it's going to happen. And it costs us a lot of money. It costs them a lot of pain. It's expensive. If you end up getting another vial of normal saline, if you need 4 grams of magnesium, which costs 4 hours of an infusion center time, it's cost to the patient, it's cost to you, it's cost to the whole center. But there's even more dire that some of our patients told us. A few of our patients said, well, every time we take HuMOLYTE, I don't get ulcers in my mouth. Why is that? I said, no, it's probably nothing to do with HuMOLYTE. Said, no, it's with HuMOLYTE. I've gone through 4 cycles, and a 5th cycle I'm taking HuMOLYTE and I don't have ulcers. Why? So again, your patient or your client is your best messenger for pivoting, I guess. We said, okay, maybe there is something, and there is. If you look at the data, what do HMOs do? HMOs are these non-digestible sugars that the mother feeds her baby. It leads to the maturation of the gut. When you don't have HMOs, your gut starts to break down. These kids get necrotizing enterocolitis, right? So why is this used in infant nutrition? Because you add HMOs to your infant formula to reduce this incidence of neck. I said it makes perfect sense. It's protecting the GI tract. So we launched this product for hydration and cancer patients. We went back and said we need to study this because this has a lot more role than we initially thought. So we went backwards. We said let's see what's available in the market. None of these things can heal the GI tract. None of this is even thought about. What can it do to protect the GI tract? Because if your GI tract is injured, you're going to keep having diarrhea. You're going to have dehydration. You're going to lose magnesium. And what we did is we basically looked at this. The formulation was already there. All it had to be is palatable. But then we wanted to know, does it actually hold true? Does it help reduce mucositis? What happens with animal studies? Does it work in humans? So we went through it. We know that in the market there's very few things that actually do this. And none of them is created as a medical hydration product that can reduce both mucositis that can prevent dehydration. That's the easy part. But can it reduce mucositis? Can it prevent your gut from a off-target effects of chemo? That was the crucial thing. And there isn't. So what it really helps is our goal here would be to make sure that chemotherapy rhymes with HuMOLYTE. Why? Because every therapy, as intense as chemo, requires lots and lots of supportive care. We don't have a cancer aisle in pharmacies right now. We should. We have diabetic aisles, we have foot care aisles, we have skin care aisles. We don't have anything for cancer care, right? We have something, take an Imodium, take a Pepto-Bismol, do this. And a lot of these people get magnesium tablets because you can't keep replacing IV. And what does magnesium tablets cause? Diarrhea. So now you're giving magnesium oxide to a corrosive gut. It's never gonna work. So we are looking at multiple things here. What the principle here is really to look at, can we reduce the intensity of diarrhea? Can we reduce the pain? Can we reduce the ulcers and recurrence of ulcers? And can we reduce the inflammation? Because HMOs are really good at reducing gastrointestinal inflammation. So what we have done here is looking at both from a cell culture models, looked at animal studies that we recently published, and we just completed a clinical trial in India in patients who received chemotherapy for solid tumors. And I might be able to show you some of the data. I'm not sure if that has. It's a big market. I don't think we need to go into the numbers. We all know it's somebody in our family who's gotten cancer. We all know that everyone has gone through chemo. None of them are going to tell you that I felt great in chemo, that I had no side effects. So these numbers are good to have from a business perspective, but we all know how big of a problem there is. So, as with any startup, finally when we find exactly which direction we need to go and which direction we need to focus, of course, like every startup, we've always had these breaks. So, hold it, we still need more money before we keep going forward. So, where we are is it all started, as you know, and somewhere here, this is where Magnac and HuMOLYTE and all of this thought process was brewing. But it's, I think, looking back, I don't look at it as a mistake. I think this is how startups evolve and really try to still struggle to find a perfect product and a perfect fit into the market. We are pretty good with intellectual property. We've protected those. We have actually quite a few of those now. We have done, we've introduced we have soft launched this product into it. We know the palatability. We know that customers want to use it. We have a good price point. But most importantly, we have efficacy studies that are not influencer based. They're science based, they're randomized controlled clinical trials. There's robust animal studies showing pathological differences when you actually drink HuMOLYTE versus or not. And where we are now is we're actually in the middle of raising a Series A to get into our first large level expansion of getting this product into the hands of people who need it the most, our patients. So what did we really learn through this? A lot. I think these are the best takeaways that I usually give on a regular basis. Is really, really, really look into your problem. And the problem should be enough that motivates you, because you will sulk every day. Why am I doing this? And why is nobody looking at this the way they should? Talk to people. I can tell you that I would not have any of these ideas unless my patients would have suggested me to do these things. So talking to people is very critical. You have to pivot. Pivoting is not an issue, it's not a problem. Pivoting is an absolute necessity in startup. It's just a matter of trying to find a perfect pitch. And then support your findings with true science. I mean, I think in life sciences, publications and peer review is really still the currency of getting you to the market. And I know in the nephrology world, I don't know if you've heard about a drug that basically was pulled out of the market, Tavneos. And if you look at it, the peer review at the time, the publications at the time, you could tell that they could have done better, And I think I put a lot of value to to getting a lot of feedback from like minds, even when we don't want it or like it. Things that you probably know, but I learned is that you really need 100% more than what you budget for. You're always running out of money.
At least. Money and time.
Money and time, and this is where, no matter what your projections are, don't do the 30% over, do the 100% over. It's twice as much. If you're gonna do good work, good science, you're gonna do that. And find a good team early. I think you need your supporters and believers, because a lot of times, startup is a very lonely journey, no matter how. I'm blessed because my wife is going through the same frustration, so we both go through it, and we both cuss. We have a cuss night, and we sit, we do it, and we share each other's. We talk to each other about who we should talk and not to talk. But I think we had a lot of core supporters. Rich came in 3 years ago, has been very influential in getting the word out and helping. But I think building a team early is very important, and nobody invests in an invisible team, so it's very important. And a rich uncle helps. So I don't know whoever tells you, but you need a rich uncle. So no matter what they tell you.
Rich.
So, go rich. So that's kind of the story. I didn't want to go into the lot of science part, but I just want to share our pivoting journey into what we have. And I think now we are in a very good place. We have enough science, efficacy studies, that we are in the middle of a good Series A, and we have a couple of handshakes from venture capital who are actually helping us find a better syndicate to have co-investors. We hope to complete this in the next 6 to 9 months, but how things are really slow. So I might be here next summer talking to you guys.
Or you might be here to celebrate.
Let's hope so. I think the sooner we do it, the quicker we get it to people. That's my. But I give the first point the biggest. You get so many rejections in startup that you have to constantly look at your problem. That's what you're trying to do. You're trying to solve something. It's important. It's meaningful. Doesn't matter. Some people may not buy it. I've had people tell me who had a bachelor's degree who said magnesium is the same as potassium, and I had to rip my hair off. And I said, okay. So there are people like that who will advise you who have no training. There will be people who will be rejecting an idea because they don't understand it, but that's the reality. We try our best to convince people and try to sell the problem more than what you can sell the solution. I think we were all fixated a lot on our solution. This is what we can do. But I think it's important to sell the problem too. But all of you have already started and far off in here, so I don't know if there's much for you to take away from here, but any questions, let me know.
When you first launched Magnet as what do you call it, ready to drink, the wet product, and you said it was sold out. What did you do for that marketing, or it was just word of mouth, or?
So no, it's what we did was that we created this in Florida for many reasons, and this person who was in manufacturing, he always worked with a sales and marketing, and this is what having a good sales team solves a lot of problems. So we contracted with someone who basically did the sales and marketing, went to the stores, introduced to the stores, stocked it, did all the basic sampling and stuff like that. And that's basically what it was. And I think that the Florida heat, getting the right people at the right time, so we spent most of our money marketing into marathons. So imagine Texas and Florida, summer months, people are running marathon. It was not a hard sell. I think what got better is our pitch of, listen, this is really to reduce your cramping because most of us are deficient in magnesium. We don't need it. The diet's not as healthy into magnesium, and so I think that got better. But that took time because we really needed to have some supportive stuff. People claim all this kind of stuff, right? We didn't want to do that. We wanted to make sure that our product actually had some science behind it. But After that, I think it wasn't, if you have a good product with the right marketing team, with the right influencer, and influencers change, marketing team changes. So I think it's important that your product and your science holds, because at the end of the day, I don't necessarily buy stuff because somebody else does it, right? I need to know that it actually is. That person just opens the door.
So if COVID didn't happen, potentially potentially HuMOLYTE would actually have happened.
Yeah, maybe.
We've been able to self-fund the whole thing.
Right.
Yep. Yeah. Or it would have happened quickly and we would have been in Florida and the North Atlantic and say, okay, do something else.
Yeah.
Just don't know.
This is direct to consumer, where it's,
Yeah.
it's
So
not
this-
regulated, it's not reimbursable, or,
It's, you can have HSAs and FSAs pay for it. Medical food is still not. Now, with medical food, you get a lot of leeway because you can very specifically market it to a disease as long as you comply with the regulatory guidelines of FDA. It helps if you have efficacy studies because you have a lesser issue with the FDA later on coming because, hey, we over-marketed this product when it wasn't doing it. But it's a D2C product and it just allows you to focus on certain things within a certain market without having, you can't just do it with supplements. It's just sort of like, with supplements you would say hydration product. With medical food, you're actually, as long as you label it as for dietary management of dehydration and chemotherapy, that's acceptable. Because you're clearly labeling it as a medical food, you have to label it that used under medical supervision. There's a couple of things to it.
Who's your co-man for the Magnet pre-workouts and for the beverages? Like, how did you get a hold of them? How did you deal with the low MOQs? I'm guessing costs were pretty high when you first did the launch.
Yeah, so with the ready to drink or? for-
Both. You said the ready to drink was in Florida. How about the pre-workout?
The powder was in SoCal.
Okay.
A lot of these companies will do 1,000, 2,000 as a minimum. By the time we had launched, so when we did the first one with James, we did a 3,000 MOQ run, which cost us a lot. And we were out in 3 months. And a lot of it was because of James. We had a good product, but James was pushing. And if you have a world record holder athlete who has 500,000 in following, it was like, we couldn't keep up with the sales initially. A lot of times, but it also gave us you have to keep doing it consistently. So when he left, trying to get other influencers and marketers can only go so far. And you can, if you have a lot of money and all the money in the world, you can put that money, as long as the product is good, it will grow. But it's just gonna grow at a different pace. You just have to have some sort of that money to invest into the marketing. And when you launch your beverage, if you spend $1 into production, or you probably have to spend $5 or $7 into marketing, right? The cost acquisition, your cost of customer acquisition, or CSC, is the most important driving factor. That's where most companies run dry, right? So you have a great thing. It's just like, man, you need a lot of cash to push it forward into marketing.
How did you find did you work with a branding agency to help with your logo, your marketing?
Yeah.
Okay.
When we initially this was an experiment. When we did a ready to drink, we probably should have done it more, but it was flying because of the formulation, right, and in the right positioning, right? Then we got, so the good thing about Florida is that there's a lot of agencies. It's almost, Utah and Florida is kind of the mecca of marketing or production of these things. So so Celsius Drink has its main manufacturing plant there. I think Body Armor manufactures Clearwater. So that's what a lot of Clearwater in Florida is about. They do a lot of manufacturing of drinks and sports products. So that person introduced us to Sack Lunch. It's a marketing and branding agency who did everything for this company called Celsius, the Celsius drink that you see. So it's cans, it's all of that. So, and they did all the logo and branding and things for HuMOLYTE, and we still do actually. We still work with them on and off. So I think getting those things right is really, really important. I mean, you have to have a perfect package for customers to pick it off the shelf, right?
Yeah.
Yeah, medical food has different challenges. You know, we're 10 of us, right? It's easy for me to say, to get Magnac to 5 of you, because everybody is drinking this, and, you know, but there's only gonna be one chemotherapy patient somewhere in the back. So the market is lower, the marketing strategy is different. It has to be a lot more education to getting it worked into the hands of these patients. So there's a lot of foundational partnership with, you know, the Breast Cancer Foundation, the Chemotherapy Foundation, the Cancer Centers of the US, those kind of things is where this is gonna be driven through. As opposed to, you know, Magnet is like, you know, you just market it to any younger person, you know. So all of these things are really important when you're going to be doing, you know, your launch, soft launch, going back and forth.
You can't get it into like infusion centers or like some strategic partnership with the healthcare providers or oncology clinics or?
Yeah, we are. So the oncology clinics possibly. Now, only about 15% of oncology clinics are independent. So if you go to Sutter Health or Kaiser or Dignity, they have no incentive to stock it. Most people don't want to stock. Most physicians do not want anything stocked in their practices. We, in our private practice, we used to stock iron, vitamins. We even give our own brokered shots, and it's another burden the practices don't want. So that's probably not, and it's not good. But integrative physicians are the only ones who will do it. There is about, you know, a sizable integrative physicians who do wellness management, symptom management. They focus on endocrine, menopause. They focus on athletics, and so that's a way. Infusion centers are sadly incentivized for infusions. They don't want to stock their competitor who drives less infusions, so they will never let us in. But health, you know, how the health system is now value-based care. It's not just Kaiser, it's VA. Sutter is going to move into value-based care, which means that there's a lot more incentive to keep these patients at home. And universally in the US, infusion centers are clogged. They get the biggest bang for the buck by infusing chemotherapy drugs and not giving them saline and magnesium and potassium, right? So generally, the understanding throughout the healthcare system is this is a good thing. Kaiser is probably the most ambitious about this, because the more we keep them at home, if you can show benefits, even better, less infusions, it's beneficial for them. But I think overall, not just Kaiser or VA, everything is going to move in that direction. And it's important to get patients, you know, better care during the chemo period, because like I showed you, right, in mucositis, you don't have to tell these patients that it's gonna hurt, just suck it up for the 3-week cycle. There's better options, and we have to do these things for them.
Have you considered hospice at all?
I haven't.
There's a lot of challenges with dehydration as folks are getting nearing end of life. And they don't always have infusion services when they're doing hospice at home. And then being able to get pain medications into patients when you can't place an IV and they don't have enough saliva to dissolve an oral medication is really difficult. So that might be a space where palliative physicians would be willing to provide that sort of support or suggest that sort of support for hospice patients.
I can definitely do that. I think it's one of the things we look at chemo also.
Look to the families. You're taking care of mom or
Yeah.
she needs HuMOLYTE.
There's a specific
Well-
market of hospice care workers.
Yeah.
Probably easier to market to.
It is.
Yeah.
Than the
it's a
sliver
focus
of
one.
chemotherapy.
Yeah.
And if I share a story, or when my sister was going through hospice, as part of her advanced directive, she had selected she didn't want to receive IV support. Now, she was thinking more like TPN kind of a thing when she signed it off.
Yeah.
And by the time, she was far enough along in the process to really reconsider that decision, she was so dehydrated we could leave it. So she went through a lot of her end-of-life care without pain medications because she was just too dehydrated to be able to process anything.
Was she able to do any other hydration, like any other fluids orally? She was not able to do.
No, and so, you can just watch that get worse and worse with time to where, suppositories don't work, you can't do under the tongue, you can't do any of those methodologies because of dehydration. And so if you look at some of those options, particularly when folks have gastrointestinal cancers where they have blockages, where, those sort of processes are happening, where they can't intake a lot of fluids orally, then dehydration happens really
Yeah,
quickly. It
absolutely.
makes it a really miserable process to go through at the end.
And I think that's a great point. I mean, the other thing we have, it's interesting, is infectious diarrhea. So when I was in New York, we had a whole bunch of transplant patients coming in with norovirus. So it's a hub. The Bronx is the hub for norovirus for some reason. And we had a lot of these, we transferred a lot of patients from Bronx and uptown Manhattan, difficult area, and they're all high risk. It's a high risk program. And they would come in with infectious diarrhea. And there was at least a few patients that I gave HuMOLYTE to, and you could see the reduction and there is, the reduction in symptoms, better hydration. I could see some of these patients, they came to the ER, we gave it to them, they were good. And if you go back, there's actually a good amount of data on norovirus and rotavirus in kids. And people have used HMOs in there, for GI injury. The other thing we're looking at also is chronic alcoholism, because alcohol changes your gut completely. And instead of a chemotherapeutic drug, this is a constant drug that's hitting your GI tract and causing magnesium wasting and dehydration. So that's a whole other market. It's a huge market. The reason we did this study with chemo also was because chemo is timed, so we could measure these outcomes very easily. Infectious diarrhea is impossible to recruit in a trial. You don't know when it's going to happen. Alcoholism is the next, because we can actually look at chronic issues with these patients and then see what happens with HuMOLYTE over a longer period. Chemo is sort of the easiest, because we know Monday you're going to get chemo, you start the HuMOLYTE, and then let's measure it on day 14. But I think we could definitely use more applications if we can. Thank you for that.
If you decide you want to do it, have a potential client that's looking at
Okay. Absolutely.
hospice support at the moment, so.
Absolutely.
We have a new guest.
Oh.
You have a chance,
I was
opportunity.
finishing a shift.
You have a
I
chance
can do it
to
on time.
introduce yourself.
Yeah. I'm Larissa May. I'm an emergency physician at UC Davis, and I've had a lot of different paths. Not been a founder, but have supported, been an advisor for startups. I was at ARPAGE for about 8 months. And yeah, I'm also the chapter lead with Sarah for the Society of Physician Entrepreneurs, and on the board. So representing today. Unfortunately, I think my group everybody's traveling or caught up in other things, but.
It is the summer.
Love them, yeah. Yeah, thank you for sharing.
Wonderful.
So what's next? What's on the docket?
Show me the money.
You're all in the Series A mode.
He's doing his best Tom Cruise.
There we go.
It's all in. So 2 most important things is looking for people. So we know who we need to bring in. We need a very solid sales and marketing director who's done this in nutrition, who can open some of the contracts, talk with hospital systems, pharmacies. That's kind of the first line of it, and then, it has to be regional and slow growth in there. So that's our first, and then there's a room for expansion of scientific committee and all of that. That I can take care of. But I think our lead is really to finish the Series A and start getting the first launch of this into it before we look for more money for growth. Yeah. We have a couple of strategic, people who are interested in, who are aligned into this sort of a medical food business. Looking into that, to see, getting the right investors with value add is very important now. So, people who have done this before, people who know the challenges of getting nutritional products into the market and doing it correctly is very important. So,
Those are the people you can call up and make something happen.
exactly. And it's in the right hands, things flow so much easier, right? People who have done it, they already know not to go in this direction versus that. So, yeah, I think it's quite, so if you know any good nutrition marketing guy, send me a text. I'll be happy to talk to him.
All right, any other questions?
Not sure about nutrition marketing, but I just think of Greg Connolly. I think his newest thing is solar,
Yeah,
but
we
like,
did the trifecta.
well, even before then, he had an energy drink called Amara. So I know that he's been in that space. He's sort of evolved and
Yeah.
he's picking bigger battles around.
It's got the battery thing.
Yeah, I don't remember what it was.
It's competing with the Tesla battery, home battery thing.
That's right.
And he just raised like $2 million from Moneta without having a product. No, he had commitments, I think is what he had, to pre-sales, is what he did, which I think impressed him.
Yeah, chemo's consistent. IBS-D, more consistent than Noro, but God, if you could get like if this could be the go-to treatment for like norovirus or something, that'd be.
Cruise lines.
I was thinking that earlier. I'm
Last
like-
week.
Exactly.
That came to mind when I was thinking about it.
I was like, yeah, they're stuck in their room and,
I mean,
they don't
it's
know what to
pretty
do for
bad when
them.
it happens on a cruise line, right? Vegas casinos, I mean, some guy was really, really interested in doing this with us, and I don't know, it didn't work out for him, but, I mean, there's a real data on how many people are hungover and have severe GI toxicity in Vegas every night.
You could replace all those clinics that do the IV.
Mobile
IVs,
mobile
right?
IV and just
Yeah.
like do this.
Just put
They
things
hand it out as you walk out of the door, right?
Yeah, you don't
Yeah.
even need to go
Take yourself
anywhere.
with you.
You don't need to go anywhere. You don't need to be hosts and you don't need to pay like $500.
Right there. Here you go, you got heartburn, you lost some money.
That was my first impression of Key West as I got off the plane. And you're going on a baggage claim and there's a sign telling you where to get your IV hydration the following morning. Like you haven't even left the
Well, that's
airport yet.
interesting. I haven't been there since like 2009 and it wasn't like that in 2009 for sure.
They know what their major product is.
Yes. Well, everybody walks around the street with their drinks,
You don't
New
need
Orleans,
pain to
New
gain.
Orleans. There you go. Mardi Gras.
Yep. So there's like, it's sort of, if you look at the intensity of what we need to solve, it's chemo. But if you look at the bigger market, right? Like if you really need a medical hydration product, general hydration is fine, but if you have diarrhea, chemo, ulcerations, chronic GERD, malabsorption syndrome, I mean everything sort of. And we haven't done the longitudinal study to actually show the microbiome effects. I think this was a linear study, 4-week trial. There was a high dose chemo period, 14 days. We had intensified sort of a treatment period during that time, and then 14 days of maintenance. And we looked at oral ulcers, we looked at gastrointestinal symptom score, We looked at fecal calprotectin levels, look at inflammatory markers, and it's remarkable in terms of results. So,
These clinical tests that were done, you didn't do these tests yourselves, right? This was already published, and it was based on the literature?
we did it.
But you did
this
everything.
trial, yeah. Now, I found the CRO. There's a few CROs that work in the US. They have offices in Philippines, India, Australia. For conflict of interest, I cannot be the PI. So my background is basically I'm a clinical trialist. So I did drug trials for a lot of companies in kidney disease, transplants, immunosuppression. But because I'm involved and developed this product, I cannot be the PI on this. So we basically gave all the preclinical data to a clinical research organization in India. I wrote most of the things I needed to look at, protocol, what we wanted to, but then they took that, they found a organization that was connected to cancer hospitals. We wanted to make sure this is only in solid tumors because, hematological cancers get a little different chemo, it's high intensity, sometimes they get radiation chemo. So we wanted a streamlined population that got the 4 to 5 specific drugs that we tested on animals on. And then we had 1 cycle of chemo. So we had to design all of this, that they did the identification of sites and all the things that with patients, recruitment, all of that, and they gave us the data. And that's very important because, we don't want conflict of interest being involved in it, to look at that. So.
How long did this process take for the clinical trials?
6 months?
Well, the trial took 6 months, but finding a CRO took another 6 months, and planning took another 6 months, and the thought process took another 6 months.
Gotcha.
And you will have to go through multiple CROs. You'll have to go take quotes. You have to look whether they're FDA certified. The important thing is, even though a lot of times, so in biotech and pharma, if you do it internationally, you may have to repeat your phase 1 clinical trials. I don't know if I'm right. But it de-risks the product so much that a lot of your investors, your venture capital will look at it and say, okay, fine, de-risk it as much as you can before you bring it up there, as opposed to doing it first. So we try to do the clinical trial here because the Western diet is different, population is different. It was going to cost us $2.5 million just to do a 30 people trial. So we did it at a fraction of the cost.
You looked at Crohn's disease, so too.
So there is data on this. We haven't looked at it, but that's the inflammatory bowel disease is a big. Now that diarrhea is a little bit different. When it happens, it's more pain and blood, and it's not so much of a volume as opposed to the inflammation. But because we have actually data that there's other things in the science of it, it's in a publication, that magnesium and HMOs actually collaborate really beautifully in reducing inflammation. I think magnesium, it's mostly because it's anti-apoptotic, so it actually helps in cell survival. So, and the intact GI epithelium allows less dissemination from the luminal surface. So the inflammation goes down dramatically. So, and you don't see the same with just HMOs. So the formulation is very anti-inflammatory, even more so than just the HMOs. This is the reason why we haven't published this, because that was a surprise for us. We had to amend our patents again. So,
This was in animals or humans?
humans. We looked at we wanted a calprotectin and lactoferrin just to see what the injury markers were. So, if we have a 20%, that's a dramatically different. And from baseline post chemo, with and without HuMOLYTE, it's opposite. It's so much reduction, 70-80% reduction from the injury markers. And it wasn't just so, mucositis is an objective sign. We could see mucositis reduction. We could see calprotectin level reduction, significant amounts. We had symptoms completely different. So we were just hoping that it would be effective in hydration. People would feel better. Maybe the grade of mucositis would be a little lower, but it's.
Does it slow gastric motility?
Now, a lot of people have, there may be some when you have a tremendous amount of diarrhea, you might see some of that, but I think it's mostly the injury of epithelial cells. But I've only known that for a preventive purpose. I mean, not after you have it, no, I've seen it. So I have to investigate that, is it repopulating it? Now, my wife pointed out a paper that HMOs actually act as decoy, and they opsonize some of these vital particles because it's a non-digestible sugar. So basically they absorb all that extra virus from the gut as it goes through and reduce the intensity of diarrhea. I just learned that about HMOs. Something new every day.
All the study, you told me this, we had a high flyer company in the gut biome space who didn't do all the studies that you did and paid the price for that. Maybe you could share that, what all happened there, but it's a cautionary tale.
Which one are you talking about? Which company?
Out of UC Davis with the gut biome.
Oh, Infinite.
What?
Infinite Health?
Yeah.
Yeah. So I know the founders and co-founders. They're co-founders of my wife's company, so I've known them for years. Amazing trio of scientists. I don't know, so, this is a probiotic. This is a bifidobacteria. I don't know which strain it is. I think it's one of the bifidobacteria. It's a probiotic in its classic sense given to NICU babies, right? And then these, basically the idea is a reduction in necrotizing enterocolitis. So premature NICU babies is what the target was. It's a very small population, niche population. I think what the issue there is we got to know, because it was on CNN, that a baby had died of sepsis, and when they did blood cultures, they could identify the probiotic. Now, the idea was whether you had so much NEC that you became bacteremic. Was it a profound bacteremia because of your gut injury? Was it only a selective bug that you gave? All of these things. So the FDA said, hold until we find out. They put a brake on it. Then they realized that the way this was done as a supplement did not have all the studies correctly. So that was a major, and this company has raised $150 million.
Oh, shit.
Yeah. And that Mead Johnson CEO, Tim Brown, who actually I know him very well, he was running it initially. They have done multiple trials, but as supplements, and did not have the right, so they almost did not have it, they should have done it as a drug, as a real randomized trial, published it. They did some of these studies, and they marketed it as something. It wasn't done correctly. I don't know the fine print of it. I know they're going the pharma route now. I don't know if you know this.
Oh, I didn't know that.
Yeah, I wasn't sure if they were going to survive all this onslaught, but they were trying to do the pharma route, do all the, so at least one of their clinical trial again, get the FDA's filing and stuff. I just thought that if you have a high-risk population like a NICU baby, you would just do it through as a, because a supplement is a drug if you're trying to treat something, right?
Mhm.
That's the fundamental.
But it was just a prebiotic, right? It wasn't the actual being
It's a probiotic. Yeah, it's a bug. It's a probiotic. It's a live bug. Now you could say that there's live bugs everywhere and in yogurt, but when you're concentrating a bug to 1 billion colony units and giving it to a high-risk patient.
Especially a teeny high-risk patient, everything is so accentuated in
Yeah.
a small population.
They've done a lot of studies for sure. I mean, they didn't. There was a huge UC Davis study from the NICU, so it was done, and they could. But the other thing what happened with them is that when that was taken off, the infant deaths rose from NEC. So FDA actually told them that if you do it right, we will support you because your product is correct. Your method wasn't exactly correct. So this is what the backdoor story is. They only have a team of 1 or 2 people now.
slides, okay.